Hi, everybody. I'm Dr. Mack, and tonight we are going to have a 3-hour CE event to discuss my research, which is focused on prescription drug abuse and also the FDA upscheduling of hydrocodone and how it's all interrelated. So we have a few questions in the chat box before we dive right in. And yes, the session will be recorded, and it will be placed in the Digital Depot for viewing at a later time, Rebecca, so you can watch the entire CE tonight. All right, everybody. So I'll go ahead and get started. The first thing that we need to talk about are our objectives tonight, and I just want to give you a little bit of background about myself. So I teach at Frontier Nursing University. I've been a part of Frontier now for a little over 3 years, and my main responsibilities, I'm the course coordinator for PC 700, which is the writing course at Frontier, and also course coordinator for NP 711, which is the skills course for F&P students. So I'm a clinical bound team leader and just have a lovely position at Frontier. Can't speak enough about it. So tonight, again, we're going to talk about prescription drug abuse, the upscheduling of hydrocodone, and the effect that those changes have had on nurse practitioners' pain management practices. So first, let's just talk about our objectives. Our objectives tonight, we're going to determine the relevance of an APRN consensus model. We're going to explain the FDA upscheduling of hydrocodone-combined medications. We're going to recognize common characteristics of drug-seeking behavior. We're going to identify whether APRN's pain management practices have changed with the upscheduling of hydrocodone-combined medications. And we're also going to analyze the clinical pain management practices that APRNs are utilizing since the upscheduling of hydrocodone-combined medications. We're going to develop an understanding of max transformation of practice theory, summarize the thematic analysis of the research utilizing the phenomenological method, and we're going to discuss how the research will impact clinical practice and future research. So let me just tell you a little how all of this was started. So in 2011, I began my focus on researching prescription drug abuse, and that's kind of how all of this has evolved. So you'll see there at the top that it says DNP Capstone to PhD dissertation. So I completed my DNP Capstone that was focused on prescription drug abuse and how you could decrease that in a clinical setting. And then that research carried over to my PhD dissertation as well. And so my PhD dissertation focused on the FDA upscheduling of hydrocodone and how it affected nurse practitioners' pain management practices. So this has been a lot of work in progress, and it's really evolved over time. And so some more background is, how did this become an interest to me? Why did I, grab a hold of the topic of prescription drug abuse, and why have I been so focused on that for the last several years? Well, let me tell you that I'm a family nurse practitioner. I live in Oklahoma, and at the time I was practicing full-time. And I had so many patients that were coming into the clinic asking for specific medications, whether it was hydrocodone or oxycodone or any other kind of narcotic. They came in and asked for these medications. I had patients demanding these medications. I had patients telling me that they were going to sell some of their food stamps so they could obtain their narcotics. And I had several patients who were addicted to narcotics, and they were struggling with their addiction, and they really just didn't have the help that they needed. So I really became focused on prescription drug abuse because I was seeing so much of it in a daily practice here in Oklahoma. Now, I was practicing in 2 locations. One was a metropolitan setting. The other was a rural setting. The settings varied drastically. When I worked in the metropolitan area, I worked with an underserved population in a lower socioeconomic class. And in the rural population, I worked with patients who had, a majority of the time, commercial insurance and lived in a more affluent area. Now, I'll say, when it came to prescription drug abuse, there was no difference between the 2 clinical settings. I was seeing the same problem in both settings, and it really was affecting my practice, and it was affecting the people that I practiced with. So we really struggled with, what are we going to do? Why has this become such a big problem? Our clinic worked closely with the DEA and the Oklahoma Bureau of Narcotics and Dangerous Drugs, and we began trying to work with them to develop a relationship to see what could we do about this problem and how could we help decrease it just a little bit. At that time, Oklahoma was listed as #1 in the United States for prescription drug abuse. So this is kind of how my focus began and why I talk so frequently about prescription drug abuse, and that's where my research is still focused. So let's move forward a little bit and talk about decreasing prescription drug abuse in the clinical setting. So we're going to cover some background information and some statistical information about prescription drug abuse, and then we're going to look at that first Capstone project and look at what I was seeing in clinical practice and what I was going to do to try to fix this problem. Now, say I love my DNP so much that I wanted to continue my education and finish my PhD in nursing education, and I was able to carry my topic over into my dissertation, which was really nice. This opportunity, becoming involved so fully in trying to decrease prescription drug abuse in Oklahoma, has really opened the doors to a lot of opportunities for myself. I work on a state-appointed work group. It's a lot of physicians and nurse practitioners and PAs and other APRNs and other key players that contribute to developing guidelines in Oklahoma to decrease prescription drug abuse in the office and in the ER setting. So my research has been very, very rewarding, and you'll see when we get to the end of this first capstone presentation that we're going to discuss, you'll see kind of how it's taken off and how we've made some really great changes here in the state, and a lot of that is really directly related to my research, which I'm very proud of. So as you know, prescription drug abuse is a really hot topic. It's talked about all the time. You'll see it in the newspapers. You're going to hear about it on the radio. You might see billboards around the area that you live. And you'll hear it in the medical community about how many providers are struggling with patients that have these addictions and the limited resources that we have to really help these patients. So prescription drug abuse has been classified as an epidemic, and it's been quite the hot topic. And over the last few years, you've heard more and more in several states about prescription drug abuse and how are we going to be able to help decrease this problem and help the patients who are suffering from addiction. And I just want to say while we're going during this presentation, if you have any questions or you want to jump in and ask a question or you have any feedback, you're welcome to do that either in the chat box or with a microphone. We will have time at the very end of the presentation for a discussion session. So prescription drug abuse continues to escalate in the United States. It does lead to an increase in emergency room visits, overdoses, and unintentional deaths. Actually, here in Oklahoma, we have more problems, more death related to prescription drugs than we do car accidents. So it really has become quite a big topic and quite a big problem. The National Survey on Drug Use and Health in 2015 surveyed approximately 68,000 people across the United States, and it estimates that 1.4% of these people over the age of 12 are current misusers of narcotic pain medication. Now, it looks like currently we have 71 users on this BBB, and I would say that there are a lot of people on this session who have either worked with patients that struggle with prescription drug abuse or who have friends or family members who have struggled with this problem as well. It really does touch everyone in some way. Approximately 3 million people have misused narcotic pain relievers over the last 30 days. So that number to me is very staggering. 3 million people have misused narcotic pain relievers in the last 30 days. That's a lot of people, and that's a lot of narcotic pain relievers. These drugs are obtained from friends, relatives, healthcare providers, drug dealers, strangers, and a lot of times they're purchased on the internet. You would be surprised at what a quick internet search can gain you when you're looking for prescription medications, and it's an area that isn't quite as well regulated as some of our other areas by state. So again, we have people that are obtaining these narcotics when they go visit other friends. They look in their medicine cabinets. Children might have access to their parents' medications. So again, the medication, what we need to remember is that the medication, usually a majority of the time, the root of the problem is coming from the provider. So that's how a majority of these medications are on the streets and are in the hands of people who are abusing and misusing these medications. The survey also identified that approximately 5 million people used prescription pain relievers over the last year. 1.9 million people used prescription tranquilizers, 1.7 million used prescription stimulants, and 446,000 used prescription sedatives for non-medical purposes. So all of those numbers are for people using these medications for purposes that they weren't prescribed these medicines, for non-medical purposes. It's further identified that just over 4% of our youth, that's age 12 to 17, use prescription medications for non-medical purposes. It's a lot of kids out there. Young adults aged 18 to 25 were identified as using prescription medications for non-medical purposes more than any other age group. Males were identified as using these medications more than females. American Indians, Alaskan Natives, and African Americans were found to use them more than other ethnicities as well. The survey also identified that people with some college education use prescription medications for non-medical purposes more than people who did not complete high school, and that unemployed people were identified to use these medications more than people who were employed. Oklahoma currently ranks in the top 10 in the nation of all categories for non-medical consumption of pain relievers. So we have gradually worked our way down the scale. We're no longer number one, which is nice, but we're still in the top 10. We're still struggling here in Oklahoma with prescription drug abuse, and our overdose death rates are above the national average, and they're directly related to prescription drugs. We're still in the midst of that epidemic I was talking about. Approximately 5% of the residents here in Oklahoma have reported using prescription medications for non-medical purposes, compared to that national average of only 1.4%. Approximately 102,000 Oklahomans are addicted to prescription medications, and the number increases every year. This is one area that we haven't seen decrease. We see some of our other statistics go down, but the number of people who are actually addicted to prescription drugs increases every year here in Oklahoma. Oklahoma has the 10th highest drug overdose death rate in the United States. And between 2010 and 2014, there were 3,500 unintentional poisoning deaths in Oklahoma, and 74% were involved at least one prescription drug. So that's a huge number. Oklahoma's opioid overdose rate in 2014 was 20.4 deaths per 100,000, which is much higher than the national average of 12.8. It's almost twice as high as the national average here in Oklahoma. Approximately 85% of the deaths were directly related to prescription narcotics, while only 15% were related to street drugs. And the epidemic caused increase in healthcare costs every year. And look at this statistic. Daily, across the U.S., over 1,000 people are treated in emergency departments for misusing prescription opioids. And this is another number that we're seeing continue to increase every year. So the number of people who are misusing and abusing these narcotic medications continues to increase, and it continues to contribute to the epidemic that we're seeing across the United States. We're spending a lot of money taking care of people and associated costs or costs that are associated with prescription drug abuse. Around $78 billion is spent on these healthcare costs that are directly related to prescription drug abuse. Healthcare providers are prescribing more narcotics than ever before, leading to an increased number of people abusing prescription narcotics in Oklahoma and the rest of the United States. We thought that upscheduling of hydrocodone-combined products was going to help us decrease the amount of narcotics that are being prescribed, but in turn, it's actually increased. The number has increased, and we're seeing more people that are struggling with addiction and limited services that are available for people who are struggling with this addiction. So the problem statement for my DNP's Capstone was that prescription drug abuse is a national epidemic. It continues to increase in size and scope every day. The problem doesn't discriminate, but it seeks out victims from all walks of life, races, and economic levels. Even worse, at that time, Oklahoma led the nation in prescription drug abuse. So this was the focus of my DNP Capstone. And so again, this all started 2011 and 2012 when I started collecting the first round of research and really started to look at the problem. And when I realized that there was this huge gap in the literature, that we weren't really talking about prescription drug abuse in some of our educational systems. We weren't talking about this in our associations. We knew it was a problem, but it wasn't on the forefront quite yet. So I created a theoretical framework called Max Transformation of Practice Theory for my DNP Capstone. And the nice thing that the development of this theory not only will focus on prescription drug abuse, but it focuses on everything that goes on in the practice environment. So I was able to carry over Max Transformation of Practice Theory and relate it to my dissertation topic of the FDA upscheduling of hydrocodone. So when we talk about Max Transformation of Practice Theory, it looked at everything that happened in that practice environment. I observed the environment, and in that environment, we have a lot of things happening. We have the patient that's involved. We have office staff, licensed nursing assistants, nurse practitioner, maybe it's a physician. So in the environment, you have all of these components, and all of those components helped me develop Max Transformation of Theory, Practice Theory. So after I looked at the environment, I looked at what was going on in the environment, and I looked at the electronic health record, the prescription drug monitoring program, which I'll talk more about here shortly, and the patient's previous medical record. So those were the objects that were included in the environment. Behaviors that I observed in the environment were the act of the physical exam and the examination of the PDMP. Now, you'll hear me refer to the PDMP much shorter than saying the prescription drug monitoring program, but just know in some states they just call it a prescription drug program or a prescription monitoring program. So you might have a slightly different acronym depending on where you live. I also examined the concepts that were involved in this practice environment, and those concepts involve the nurse practitioner's daily practice, addiction, the PDMP, and change. You can see, here's a diagram of the transformation of practice theory, and you can see how it's all interrelated and connected, that you have the clinic, and the clinic is directly related to the nurse practitioner. The nurse practitioner is related to that education. The education goes right into the implementation, up to the chemically dependent patient, and then the referral and the appropriate treatment of that patient. And so we're going to look a little closer at some of the information that came out of Max Transformation of Practice Theory during our presentation tonight. Here's the theory diagram. I know it's a little difficult to see. I had to scrunch it down to make it fit on that slide. But once you look at this a little closer, and if anybody would like copies of this a little larger, just send me a private email. I'd be happy to help you with that. And you're always welcome to send me a private email if you have any questions or want to talk about this topic in more detail. So I'll just go ahead and say, and I'll put it in the chat box here a little later, but my email address is rachel.mack@frontier.edu. But you can see that the theory diagram really will work with other problems that are found in the clinic, whether that's prescription drug abuse or another area that's been identified that needs to be changed. So you can make this theory fit with many situations and can really help you transform practice in a variety of areas in the clinical setting. So when I was reviewing the literature and looking at this research for the first time, I identified that there was very little information regarding the PDMP in the clinical setting and no information about the impact that it could have on decreasing prescription drug abuse. At that time, the PDMP was being utilized by many states, but it wasn't being used to its fullest ability. So let's talk a little bit about what is the PDMP and what does that mean. So this prescription drug monitoring program is a program that a majority of states now have, and some states can talk back and forth to each other. So it's a nice tool for providers. We are able to type in a patient's name, their date of birth, and if you can communicate or have interstate communication, you can look at other states outside of where you reside and see what medications, if any, and who have prescribed these medications to your patients. Now, it gives you a snapshot view. I can go back in Oklahoma a total of 5 years, and I can look at what medication was prescribed, who prescribed it, where the patient filled the medication, and I can look at the information that was given to the pharmacy on the patient's given address for that pickup of medication. So the PDMP really has really developed and is such a better tool than it started out many years ago when I started this research. Hi, Carolina. Alaska provides a PDMP for our state and also several other states, which I find useful every day. Yeah, so here in Oklahoma, we're required to look at the PDMP for every new patient and for any time that we are prescribing a narcotic medication, and then the information must be entered by a pharmacist within 5 minutes of dispensing the medication. So we've really tightened up our system here in Oklahoma, and it really has become a very useful tool. So after I identified that there was this huge gap in the literature about the PDMP and the clinical setting and its impact on prescription drug abuse, I also identified that we needed further research in this area. We needed to verify that we could create a program and that it really would help decrease the epidemic of prescription drug abuse in the clinical setting. So more, the review of literature, we're looking at healthcare providers, and we identified that the PDMP could be a useful tool in reducing prescription drug abuse, but it is only effective when the providers utilize it. So again, there's really very limited information that was available about the PDMP. It's also said that the program has a potential to create a collaborative regulatory environment for healthcare providers that will in turn reduce prescription drug abuse in the clinical setting. Now, the work group that I was appointed to, when we started making the changes to requiring the PDMP use by providers, we met a lot of resistance. We had a lot of providers say that it was too time-consuming, that they didn't have time to check this information. And so our Oklahoma Bureau of Narcotics and Dangerous Drugs worked with the DEA, and we're able to set up a system so providers can assign their login and password to someone in the clinic, such as a nurse, and the nurse can pull this information before the provider sees the patient. So we were able to eliminate some of those concerns about time and providers being overworked and seeing a lot of patients during the day. So we were able to nip that in the bud and move forward in a positive direction. So prevention. In 2011, the United States Office of National Drug Control Policy developed a prevention plan to decrease prescription drug abuse. Now, this plan that they developed focused on several areas. The first area was education. Now, this included education in a variety of ways. This was education for providers. It focused on trying to implement education into schools, such as higher education for providers, that they were gaining that information on prescription drug abuse. And it also focused on education to children and other adults. So they were looking at implementing education in the schools so they could try to decrease prescription drug abuse. The next part of this plan focused on implementing the PDMP. And it really stressed that, how important it was that we have such a great tool and that we need to utilize this tool in order to help decrease prescription drug abuse in the clinical setting. Now, it focused also on medication disposal. And at this time, medication disposal was a fairly new concept. Currently in Oklahoma, we now have drop boxes at most all of our Walgreens and CVS and in all of our county police stations. So patients are able to take their old or not quite finished medications and put these medications into a disposal system that's in a safe location. And then what we're doing here in Oklahoma is we're turning those into usable energy. So I'm hoping that this will spread across the United States and we can make some sort of positive experience come out of all of these medications that are being disposed of. The last area that the drug control policy looked at was enforcement. And it looked at enforcement a lot of different ways, keeping these medications off the streets, out of the hands of people that weren't prescribed these medications, trying to get a handle on the illegal medications that are coming across our borders, and also looking at internet enforcement with purchasing prescription medications. So a majority of healthcare providers in the state of Oklahoma, at the time, they're registered to use the PDMP, but evidence showed that they were not consistently utilizing the system. We needed to have a comprehensive program. It needed to be developed to educate healthcare providers about the epidemic of prescription drug abuse that Oklahoma was facing and the significant effect that proper utilization of the PDMP could have on decreasing this epidemic. So the project objectives were to design an educational program that integrates a critical pathway for healthcare providers and focuses on appropriate utilization of the PDMP. It also looked at implementing the education program in the clinical setting and then evaluating the educational program's effectiveness of decreasing prescription drug abuse by conducting a survey of healthcare providers after successful implementation of the program. So the purpose of the Capstone project is to develop an educational program for healthcare staff. Now, this educational program also included a critical pathway for healthcare providers, and this was in hopes to decrease prescription drug abuse in the clinical setting. So when we talk about the design of the educational program, it looked at holding a scheduled meeting with the people that were involved in my project, which were nurse practitioners. And I was holding this meeting to present and discuss the content in the educational program. The program was evaluated by 3 nurse practitioners that were licensed in the state of Oklahoma. And those nurse practitioners worked in a variety of practice settings. A rural family practice, a metropolitan family practice, and I included a nurse practitioner that worked at a university student health clinic. We wanted to get an idea if this educational program, or I wanted to get an idea if this educational program would work in a diverse practice setting. So the patient population included all income levels, all races, all genders, and these were patients that had a variety of acute and chronic illnesses. The return of the completed educational program questionnaire was used to evaluate the program, and that signified consent from the FNPs who were involved in my research. The practice setting project goal was that the educational program will be provided to the FNPs for review and feedback on the effectiveness of the program in decreasing prescription drug abuse in the clinical setting. And the project timeframe, it occurred over approximately 6 months. So the nurse practitioners that were involved in the project had a lot of time to implement and to really utilize the guidelines that were made and developed for the educational program to help decrease prescription drug abuse in the clinical setting. So the first 3 months, the educational program was developed to consist of several components. The components included statistical data of prescription drug abuse, the characteristics of chemically dependent patients, the utilization and analysis of the PDMP, the selection and implementation of a pain management contract, and the critical pathway. All of this information was put together in packets for the nurse practitioners who were participating in the implementation process of the educational program. The last 3 months, we received approval from IRB, and the project was expected to meet the designated criteria for the exempt status based on those guidelines. The participating FNPs were then notified, and a meeting was scheduled to discuss that educational program. I met with the 3 FNPs to present the program Questionnaire and to talk about how we were going to implement this based on the practice setting where each FNP practiced. The information was then quantitatively analyzed, and the data from the educational program Questionnaire after a month of implementation. And then I submitted a project report. This was, I didn't really have much of a budget. The only thing outside of just, my time, I paid for making copies for the packets to implement the educational program in the clinical setting. So again, the FNPs had about a whole month to evaluate the project. We talked about it for a long time, talked about the implementation process, and then they had a month to evaluate the project. The FNPs completed the educational program questionnaire, which evaluated how well the learning objectives were met. I did collect demographical data, and the questionnaire was quantitatively analyzed utilizing a 4-point Likert scale. So my first objective was the ability to access the prescription drug monitoring program. I included a step-by-step guide. We had a lot of nurse practitioners and a lot of other healthcare providers in the state of Oklahoma who were registered at one time for the PDMP, but they weren't using it consistently. A couple of my participants had to, re-identify their login information so they could access the PDMP, and I worked with them one-on-one to complete the process and completed a step-by-step guide of how they needed to look at the PDMP, when they should look at the PDMP, and what information they should glean from that data that was provided. The participants then participated in a return demonstration, and I evaluated this question. It was question number 3. I'm able to discuss proper utilization and analysis of the data in the PDMP. The results, so program success for all of my questions was set at 3.0 or higher on a 4-point Likert scale. I didn't encounter any barriers, and no prior research supports the findings of the objective. The first objective, the mean score, was 3.67 on a Likert scale, and facilitators that made this objective achievable were the willingness of the FNPs to participate, the step-by-step guide to utilizing the PDMP, internet availability, and return demonstration. Objective 2 was to increase data entry on initial use of the prescription drug monitoring program. Again, we already discussed that I provided a step-by-step guide and return demonstration. This also evaluated question number 3, that I'm able to discuss proper utilization and analysis of the data in the PDMP. I will say during this research, we identified that according to Oklahoma state laws, you're unable to legally attach the information from the PDMP to an electronic health record. But you are able, as a provider, to type all of this information gleaned from the report in the disposition when you're seeing the patient. So this came to light, and it made for another change with the PDMP and the system and how we were utilizing it here in the state. So again, the mean score was a 3.67 for objective number 2. I didn't have any barriers, and prior research supports the findings of this objective. Objective 3 was the ease of application of the critical pathway in the clinical setting. We had discussions of handouts and stating the understanding of the critical pathway. And I have a picture. Again, it's a little small because of the presentation, but I have a picture of that critical pathway that was utilized in the educational program. So this also utilized the 4-point Likert scale, and I needed to make sure that the participants could define prescription drug abuse, that they could identify characteristics of a patient who may be chemically dependent, that they could discuss the importance of using a pain management contract in the clinical setting, and they demonstrate the use of that critical pathway. Now, an example of a pain management contract was also included in the educational packet, and that was available for implementation and further use beyond the educational program if the providers deemed that they wanted to adopt that for their healthcare clinic. There were no barriers encountered. The facilitators made the objective achievable. And again, we utilized those handouts and return demonstration. This was a very involved educational program, and it was great to see how willing the FNPs were, not only to participate, but how it did make a difference with their clinical practice and the way that they were prescribing narcotics. So with Objective 3, are you able to define prescription drug abuse? My mean score was 3.33. Can you identify characteristics of a patient who may be chemically dependent? My mean score was a 3.33. Can you discuss the importance of using pain management contract in the clinical setting? A mean score of 3.67. And are you able to demonstrate understanding of the critical pathway? A mean score of 3.67. Objective 4 looked at the critical pathway facilitates pain management using evidence-based practice guidelines. Now, this was again included in that packet, and we sat down and we really looked at this pathway that was developed. The pathway, I spent a lot of time developing. You know, it's hard to develop a pathway that is comprehensive, that is easy to follow, and that it doesn't involve too many steps or too much information on the pathway. So it was a real challenge to look at the evidence and to identify the information that needed to go on that critical pathway. So we utilized that 4-point Likert scale again to evaluate question 4 of the educational program questionnaire, looking at defining prescription drug abuse, identifying characteristics of a patient who may be chemically dependent, discussing the importance of using a pain management contract in the clinical setting, and demonstrating the use of the critical pathway. Again, no barriers were encountered, and the facilitators made this objective accomplishable. So the results from can you discuss the importance of using a pain management contract, the mean score was a 3.67. Also had a mean score of 3.67 on demonstrating understandings of the critical pathway. Here are a few comments from the educational program questionnaire. I think it's a great start for providers to use to help monitor controlled substances, and it certainly is usable and user-friendly. I really think a lot more about using the PDMP website and how important it is to practice in prescribing narcotics. I'm a strong believer that the process is simple and has a great impact on clinical decision-making, patient care, and safety. So some recommendations that were that kind of came to light from this first dive into researching prescription drug abuse was that it was important to implement and expand MAC's education program into a variety of clinical settings. You know, it looked at the dangers of prescription drug abuse, identifying those chemically dependent patient behaviors, use of the PDMP, and the pain management contract. And it was a comprehensive educational program that could have been easily, and that has been easily implemented into several practice settings. It's also identified that healthcare providers should utilize the PDMP at each visit when a patient complains of pain. And that if we, all of us together, all providers really work together to make sure that we were utilizing the PDMP, and we really could make a huge difference. And if we could then use that information to talk to other healthcare providers that might not know that their patient is coming to you for pain, or that they've been to several other providers in the last few days. So making this more of a collaborative experience for the information that the provider gains or learns from that PDMP. Healthcare providers should utilize and implement pain management contracts. This was huge progress in one of the clinics where my educational program was implemented. The nurse practitioner did quite a bit of pain management and did not have pain management contracts. We worked together to develop a pain management contract that she could utilize in her clinic. And utilizing this pain management contract really helped her manage pain better, and it helped the patients understand their responsibilities when, as a patient being treated for chronic pain in the healthcare setting. Here is a picture of my pain pathway. Again, I know the print is really, really small. I had to squish it down so I could make it fit the slide, but if anybody would like a separate copy, you're welcome to send me an email and I can send you a copy of the pain pathway. All right, so that was the first kind of big dive that I took at looking at prescription drug abuse in the clinical setting, and why I got interested in this topic. And then, what did I want to do next? So I'd finished my DNP, and I didn't feel like my research was complete. After I finished my DNP, that was in 2013, we had made significant progress here in Oklahoma decreasing prescription drug abuse. I just didn't feel like it was enough. And then we were hit with this big surprise that the FDA was going to upschedule hydrocodone. And this really did have a huge impact on nurse practitioners in several states that either had a collaborative or supervising type regulations in their state. So in Oklahoma, we are able to prescribe Schedule 3 through 5 narcotics. And when hydrocodone was changed to a Schedule 2 narcotic, it took one of our tools out of our toolbox. And all of this happened right when I was finished with my DNP. So I thought, we're already struggling with prescription drug abuse, and now we are further limiting practice for nurse practitioners here in Oklahoma and for other states across the U.S. And I felt very strongly that I needed to do something more with my research. I felt like I had just started and I wanted to do more. So, at this point I was working full-time and in education, and I was practicing part-time, and I still struggled with patients with prescription drug abuse and what to do to help these patients. The limited resources that we have available in Oklahoma to help patients who are addicted to drugs of any type are very, very limited. So I was really struggling with that aspect, but then when the FDA upscheduling occurred, again, it took that tool out of our toolbox here in Oklahoma, and I know that we were very affected. On Saturdays, I work in a rural clinic. I see a lot of farm injuries, and all of a sudden, I had nothing to treat acute pain. I was kind of boxed into a corner and had, Tylenol 3 and Ultram. And so when I sat back and I thought, I've got to do something more with this research. What better way to do that but to dive right into my PhD in nursing education. I felt that the DNP made me a very well-rounded clinician, and that the PhD in nursing education would make me just as well-rounded as a nurse educator. And I thought, what a better opportunity to research. So I continued after I was accepted and I got to, the part about my dissertation. We had already been in the midst of this upscheduling for a little while, and we were seeing the effects of having this one tool removed from our toolbox, and seeing the gastric effects that Tylenol with codeine had on people, the limited availability or the limited options for choosing, how much certain medication, like with hydrocodone, we had options of really picking how many milligrams of hydrocodone and acetaminophen that we wanted. We could have more options and fewer options with Tylenol 3. And then we ran into, a lot of side effects with Ultram. We weren't using Ultram a lot. And so, this was supposed to be the big answer to really decreasing prescription drug abuse, and hydrocodone being targeted was supposed to help that. So now we're going to dive into the FDA upscheduling of hydrocodone and the effect on nurse practitioners' pain management practices. And this research began, that would have been in 2014, and was concluded and finished the end of last year, so the end of 2016. So let's just start off with an introduction. And again, if anybody has any questions, you're welcome to join in the chat box. So APRNs have been providing care to patients for over half a century in primary, acute, and specialty healthcare settings. These expert clinicians order, perform, and interpret diagnostic tests, diagnose and treat acute and chronic conditions, prescribe medications and treatments, and focus on health promotion and disease prevention while managing the patient's overall health. The scope of practice for APRNs differs across the United States. We now have 24 states that currently allow APRNs to practice autonomously, and the remaining states require some degree of supervision or collaboration with the physician. So the upscheduling of hydrocodone-combined medications occurred as a direct result of its high abuse and misuse potential. These combination medications are the most widely prescribed by healthcare providers in the U.S. and have been directly associated with the increase in drug abuse, diversion, and misuse. Prescription drug abuse continues to escalate in the United States and is contributing to an increase in emergency room visits, overdoses, and unintentional deaths. The Centers for Disease Control and Prevention have classified prescription drug abuse as an epidemic and the fastest growing drug problem in the nation. Oklahoma ranks in the top 10 in all categories for non-medical consumption of pain relievers, and approximately 8% of these residents report using prescription medications for non-medical purposes, compared to that 4.8% nationally that we'd previously talked about. We talked about previously how over 100,000 people in Oklahoma are addicted to prescription medications, and this number continues to increase each year. In 2011, with my original research, the number of people that were addicted to prescription medications was around 87,000, and then in 2015, that number had jumped up to just over 100,000. It was at 103 and 103,000 and a few extra. So in 2008, there was a consensus model developed for APRN regulation, and it was developed as an effort to standardize the regulations for APRN education and licensure across the United States. The model would potentially standardize the regulatory process for APRNs, and this would in turn increase state-to-state mobility for practice and increase access to APRN care nationwide. In Oklahoma, APRNs are unable to practice to their full educational scope. APRNs must have a collaborative agreement for prescriptive authority with a supervising physician who's licensed by the State Board of Medical Licensure or the State Board of Osteopathic Examiners in Oklahoma. Now, this physician must be accessible for collaboration, whether this is by phone, email, in person, and this person must reside in the state of Oklahoma. In order to prescribe Schedule 3 through 5 narcotic medications, an APRN in Oklahoma must be registered with the DEA. Now, when we talk about having this collaborative agreement for prescribing for APRNs here in Oklahoma, some nurse practitioners in the state are lucky enough to know a physician who doesn't charge for them to sign that one piece of paper, but I have other nurse practitioners that I know personally here in the state that are paying upwards of $10,000 to $15,000 per year to have that piece of paper signed for prescriptive authority here in the state. Now, the FDA Advisory Committee, they convened in the beginning of 2013, and they discussed changing hydrocodone-combined products to Schedule II narcotic, which would heighten the regulation due to the high abuse and misuse potential. Yeah, the stories that you hear about the amount nurse practitioners are paying for that one piece of paper is astronomical. And you'll hear stories from nurse practitioners that, they don't know their supervising physician. They have a phone number in case they need to call for collaboration. But you'll have nurse practitioners who've worked for many years and they've never met this person face to face. They just pay a high price to have this piece of paper signed and submitted to the Board of Nursing so they can continue practicing here in the state. All right, so let's look at this problem statement. We've already discussed hydrocodone, the abuse potential, and that Oklahoma was leading the nation in prescription drug abuse. It's not a statistic that we're proud of in Oklahoma. The epidemic prompted the FDA Advisory Committee in 2013 to recommend and then enact, the upscheduling of hydrocodone-combined products by tightening the regulation of these highly abused medications. This upscheduling has affected APRNs across the U.S. Hydrocodone medications were previously a Schedule III narcotic, but after this upscheduling, they changed to a Schedule II. And in many states, APRNs aren't able to prescribe Schedule II narcotics. APRNs do understand the epidemic of prescription drug abuse, misuse, and diversion, and we've been educated and trained to properly prescribe these medications. This upscheduling has further limited the scope of practice for many APRNs across the United States, which in turn has limited access to health care for many patients in rural and underserved communities. So when we look at the purpose statement and the research question, I wanted to identify whether APRN's pain management practices had changed with the upscheduling of hydrocodone, and what clinical pain management practices are APRNs utilizing since the upscheduling of hydrocodone-combined products, and what meaning do these changes in prescriptive authority have for APRN comprehensive practice? So the study explored the changes APRNs have felt were necessary in their practice to provide appropriate pain management to their patients in response to the upscheduling of hydrocodone-combined medications. In addition, APRNs are asked to reflect on the significance of the changes in providing comprehensive patient care. It's also significant to identify if this change in classification of medication affects the way APRNs adequately treat pain in the clinical setting. So, I looked at my assumptions, and there are a few areas that I was wrong, and it's okay. It made for a better study. So some of my assumptions included alternate methods to hydrocodone-combined products, and that nurse practitioners were utilizing these alternate methods to hydrocodone products. Now, say here in Oklahoma, we have some crazy rules, in my personal opinion, when it comes to APRN practice regulations. So we wanted to, decrease prescription drug abuse by upscheduling hydrocodone-combined products, but at the same time in Oklahoma, nurse practitioners are unable to refer a patient for physical therapy. So that was one of the interesting things that we ran into during this upscheduling, is we thought that maybe that would be changed so we could at least utilize some alternative therapies, but it wasn't changed. So I have a question that says, how is the upscheduling of hydrocodone or restricting APRNs helping the epidemic? Well, so it's an interesting question. We did a comprehensive study here in Oklahoma over the last year through the Association of Oklahoma Nurse Practitioners, and that study identified that after the upscheduling, the amount of hydrocodone combined products being prescribed is even more than what was being prescribed after the upscheduling. So we know that in Oklahoma, nurse practitioners didn't have any effect on that. So it was the other providers who still have access to prescribing this Schedule II narcotic products are prescribing more than we were back in 2011, 2012, before this upscheduling occurred in 2013. So it's not helping the epidemic, and that's what a lot of my research looked at was what are we doing and how can we make this better based on what we have left in our toolbox. It's been a struggle. So another assumption was that geographic location affects access to healthcare, and this is based on, a lot of our patients here in Oklahoma living in rural and underserved communities, unable to provide transportation for themselves to drive into the metro area or to drive into the more populated areas to see those specialists. Would be good reason to take measures to change the law. The way it is now seems to blame APRNs. I agree, and I think we all have to come together and work hard in all of our associations across the United States, that all nurse practitioners come together with one voice to move forward. 24 states full practice authority. We need to continue to move forward one step at a time and involve the states who have succeeded in accomplishing full practice authority. Another assumption was that healthcare coverage affects access to healthcare, and we all know in healthcare that access to healthcare coverage and insurance does affect access to healthcare for patients. And it also looked at comprehensive healthcare practices. So the phenomenological assumptions are focused on the fundamental qualities of the phenomenon which was being studied and how it relates to the environment in which it occurred. Now, this links those smaller areas of the studies to the broader areas of the studies, and explaining the underlying assumptions can really help assist in making new information more readily and acceptable. APRNs are utilizing alternative methods to hydrocodone combined products to successfully treat acute pain and low back pain, and that we are consulting and referring as necessary for chronic pain management patients. And now this does have a positive impact on the patient's well-being and decreases prescription drug abuse. The geographic locations affects patients' access to care, and that had a negative impact, or the assumption was that it had a negative impact on the patient's overall well-being. And that healthcare coverage affects those patients' ability to access those services, which again can have a negative impact on the patient's overall health and well-being. And that comprehensive healthcare, including pain management, is a goal of APRN practice. We are educated and trained to provide comprehensive pain management to our patients, and we need to be able to lift the restrictions in other states to allow full practice authority and to allow nurse practitioners to practice to their educational ability. Alaska has a huge opioid abuse epidemic right now. With our small communities and limited access to care, this has been an ongoing issue for medical providers. Another comment, it would seem that these stats would be helpful for AANP to disseminate to all state groups to assist in influencing legislators to change prescribing regulations. I agree, and one of our biggest stakeholders here in Oklahoma has actually been the AARP. The AARP has really gone out of their way to help us fight for full practice authority, and we haven't been successful yet here in Oklahoma. It's still an ongoing process. But we're going to try again this year, and hopefully every year we make headway and more progress, and we can continue moving in a positive direction. We'll talk some more at the end of the presentation about this consensus model and how it would really transform practice across the United States by having a consensus model for state practice in every state that was the same, instead of practicing so differently across the United States. So we looked earlier at the foundational framework, and that was Max Transformation of Practice Theory. And we have discussed all of the things that were involved, and that included the elements in the environment, the objects that were within the environment, the behaviors in the environment, and the concepts that were involved to developing this transformation of practice theory, and how this theory can be used in any clinical practice area to identify a problem and help to change that problem or fix that problem. All right, so I had a big literature review. Some of my information from my DNP did carry over to my PhD literature review, but by that time everything was outdated and had to be updated. So that was a lot of fun. I enjoyed the process of updating my literature review and seeing the information that was available when I completed my DNP capstone, and how the statistics had drastically changed by the time I completed my literature review for my PhD. Carolyn says, I'm at the VA and we have consistency model in place across all VAs. Yeah, we're going to talk about a few models that are available here at the end, and a few practice models that other places have implemented for opioid prescribing. So when we talk about the literature review, a comprehensive review of the literature was completed, and it focused on APRN's pain management practices after the FDA's upscheduling of hydrocodone-combined products in 2013. There was limited information available about the effect of upscheduling of the hydrocodone-combined products on APRN's pain management practices. It really was never discussed. It was kind of like we were back in the shadows, and this was changed, and we were never really brought into the discussion or discussed how it would affect our patients' access to care. The key components or the key concepts that are associated with the upscheduling of hydrocodone and the effect on nurse practitioners' pain management practices were researched. Okay, advanced practice registered nurses have been treating patients in a variety of settings for decades. We've talked about how we are expert clinicians, and we diagnose and treat health conditions which are focused on disease prevention and health management, and we take a comprehensive approach. APRNs must complete a master or doctoral program and undergo a rigorous national certification in order to be recognized as a healthcare provider. APRNs participate in periodic peer review, clinical outcome evaluations, healthcare forums, clinical research, and also we must adhere to a code for ethical practices. So when I was looking at this literature, it talked about APRNs participating in self-directed learning and professional development, and how that's required to maintain clinical competency and licensure, which isn't different from other healthcare providers. We've talked briefly about the scope of practice for APRNs in Oklahoma, and how we must also have a master or a doctoral degree, and we have to pass that national certification here in Oklahoma to practice. We can order, perform, and interpret diagnostic tests, diagnose and treat acute and chronic conditions, and we can prescribe medications and treatments to manage a patient's overall care and provide patient counseling and education on disease prevention and focus on positive health and lifestyle choices. Now, 2 areas where we are limited, 3 total that we're limited here in Oklahoma, is that APRNs in Oklahoma are unable to refer patients to physical therapy. We are also unable to sign home health records, and we must have a supervising physician for prescriptive collaboration. Now, we've talked a little bit about that supervising physician, and they must be licensed by the Board of Medicine or the osteopathic examiners, and that some APRNs pay very, very high prices to have this piece of paper signed every year. And now just think, if you were in a setting and there were multiple APRNs in that setting, one supervising physician for collaborative practice for our prescriptions can only supervise 2 APRNs. So if one clinic in the middle of nowhere, Oklahoma, was being charged $10,000 per provider to sign a piece of paper, you can see how this can really increase the cost associated with running a clinic here in Oklahoma. So we are limited to prescribing only Schedule 3 through 5 drugs, and we have to comply with the regulations that are set forth by the DEA. Although there are state requirements for APRNs to have that supervising physician, we can practice independently with off-site collaboration. So this it says, sorry, your voice cut out for a second. How many APRNs did you say a physician can supervise? 2. So one physician can supervise 2 APRNs. All right, so you can see that, if a physician's charging $10,000 to sign this piece of paper, and he has 2 nurse practitioners that he's signing the paper for, that's $20,000. So that, I think, is where a lot of our pushback for full practice authority in Oklahoma comes from, is that a lot of physicians will lose quite a bit of income, and it's not helping us when it comes to fighting for full practice authority, which is sad. So again, we can only prescribe those Schedule 3 through 5 drugs here in Oklahoma, and we can practice independently with this off-site supervision, collaboration. We don't have any requirements for the physician to perform any kind of chart reviews here in Oklahoma, and we do not have any requirements for the physician to meet with the APRN, but rather to be available via telephone or other communication device in the event that the APRN needs to collaborate about a patient's health care. Is the term supervising in your NPA? Carolyn, I'm not exactly sure what you're asking. So we're supervised for collaborative prescriptive authority. I know what a crazy term that sounds like, but that's how our Board of Nursing has it laid out, that we have supervising practice for collaborative prescribing. Does that answer your question? Yes. We would like to take out supervising. I'm hoping one of these days we're going to have to just keep moving forward slowly but surely, and we all have to come together. I think that that's a really big piece of the puzzle, especially in Oklahoma. We have an association of nurse practitioners, but this really is comprised mainly of family nurse practitioners. It doesn't, we don't have a lot of participation from other specialties. And so I think, having everybody come together and really working on this problem as one cohesive unit would be very, very helpful. So we continue looking at the literature review, and I looked at the consensus work group that the National Council of State Boards of Nursing, APRN Advisory Committee statement that was released in July of 2008. Now, this statement that was released was endorsed by 48 organizations, and they represented a variety of nursing professionals and regulatory groups. It was developed as an effort to standardize the regulations for APRN education and licensure, and each aspect of the model would standardize the regulatory process for APRNs, which would in turn increase state-to-state mobility for practice and would provide an increased access to APRN care nationwide. Natalie says, yes, Hawaii used to be like that, collaborative, but yes, we won legislation. We have full practice authority. Awesome. Illinois just finally is having our WCA eliminated as of 1/1 of 18. That's exciting news, Teresa. I just hope we continue moving in a positive direction and that we all end up with full practice authority across the U.S. It would make it so much easier for us to travel across state lines, especially so in areas like Oklahoma. If you're in the panhandle of Oklahoma, you could theoretically in half an hour drive to, Colorado or New Mexico or Texas. And so for providers that are living in those areas that are in the corner of a state, could easily travel across state lines to work. But currently, it can be a very cumbersome and expensive process for us to to cross state lines. We've also received support from the National Governors Association, the Federal Trade Commission, and the American Hospital Association for full practice authority. Now, we talked about that FDA upscheduling in 2013. Now, that upscheduling required tighter regulation on these hydrocodone-combined products because of its high abuse potential. And that committee recommended upscheduling hydrocodone products from a 3 to a 2, and this went into effect in November 2013. Now, there were also implications for APRNs in states with Schedule 3 through 5, which we'd already talked about. These providers were limited. They are no longer able to manage previous chronic pain patients with hydrocodone-combined products because it's now illegal to prescribe in these states. So this has made it difficult for providers and patients, and the referral waiting list for pain management can entail a very long wait time. Did just see a recent article that was produced saying that they are going to decrease, or I guess the DEA is becoming involved in states, and they're going to decrease the amount of product that's even produced. So that's on the coming next down the pike. I'd like to see what happens with that and if it makes a difference. So APRNs understand concerns about diversion and abuse of opioid medications. We possess the knowledge to safely prescribe controlled pain medications to patients. In addition, the federal and state authorities already developed documents to guide prescriptive practices, such as the National Drug Control Policy, which discusses prevention, implementing the PDMP, medication disposal, and enforcement. In Utah, we have full prescriptive authority after having a collaborative agreement with the physician for the first 2,000 hours of licensure. I've seen a lot of states that are going in that direction, Maria. Many VAs have FPA, SC, just voted no. Each facility votes on their own. I didn't realize that, Carolyn. I thought when the full practice authority went into effect, it was for VAs across the United States. I didn't realize that it was facility specific. Thanks for bringing that to my attention. And so I kept looking at the literature, and I looked at all of these types of pain. You know, there's acute pain, chronic pain, low back pain. There are a ton of different types of pain syndromes. But first I looked at acute pain, which is usually the result of a tissue injury, but it can also occur without an identifiable cause. The pain resolved when the injury heals, and that's usually within 6 to 12 weeks. Now, this is the most common reason for patients to self-medicate or to visit a healthcare provider is for acute pain. And I know that I see patients, you know, of a variety of levels. I have patients that wake up and their big toe hurts and they come to the clinic that day because their toe's been hurting for a few hours. Or I have patients who have lived with pain for many, many years, and they are just trying to make it every single day to manage the chronic pain and to live the best life that they can while they're dealing with that pain. So it's a big variety that we see in the clinic. Pain syndromes are commonly seen in the healthcare setting and are the third most widespread health problem in the United States. Now, chronic pain costs a lot of money. It's costing us approximately $65 billion in disability costs, loss of productivity, and the number continues to increase every year. That's a lot of money that we're spending to treat pain. Lower back pain can be categorized as a potentially serious disorder, a degenerative disorder, or nonspecific disorder. And this type of pain is typically seen in patients 20 to 40 years old, and about 70 to 80% of people have experienced low back pain at one point in their life. I bet many of us on the call tonight can say we have had that low back pain. So let's discuss in the literature some of the common characteristics of drug-seeking behavior that I identified while I was doing my literature review. And I know that a lot of you can identify with this information in practice, and that you've probably seen a lot of patients who describe this type of unusual or drug-seeking behavior. Now, this isn't typical for all patients who complain of pain, but it was an area in my literature review that I wanted to focus on. Now, I'm sure that you've seen patients who come in and they have unusual behavior while they're sitting in the waiting room. They feel a little restless. They're, looking around, maybe look a little bit paranoid. Sometimes these people have assertive personalities. They can be very demanding. Sometimes they have extreme or unusual appearances, and they seem to know everything about the symptoms. They can describe textbook symptoms. They can tell you when it started, how long it lasts, how long it's been going on. But again, sometimes their responses are very vague or evasive. These people, at times, hesitate to provide accurate and detailed information. They lack a regular doctor. They lack health insurance. They request specific narcotics. They have a list of drug allergies. They don't keep their appointments. They're never interested in a diagnostic test, and they're not interested in finding a diagnosis. They refuse to have consultations with specialists. Sometimes they have exaggerating, simulating, or malingering symptoms. They might have mood disorders, mood disturbances, and a lot of times these people have a system in place to obtain narcotics. So they might demand that they need to be seen right away, that they report that their prescription has either been lost or stolen, and they have elaborate stories that are surrounding these lost or stolen prescriptions. Sometimes you'll see these patients request appointments towards the end of the office hours. They don't have a permanent address. They request frequent refills. They fabricate physical and psychological problems. Again, they have multiple drug allergies, specifically to narcotic medications. And they state that their usual provider is either out of town or they won't divulge that information and give a name. Yes, this is going to be recorded and housed in the digital depot. Be sure you don't work at a VA emergency department. No, Carolyn, just in Oklahoma. And I practice 1 day a week and on Saturdays currently, and not a day goes by that I don't have a patient in the office, unfortunately, with drug-seeking behavior. I have a lot of patients who have true acute, chronic, or low back pain, but it's not a day that I practice goes by that I don't have a patient who is trying to seek narcotics. We've actually had a sting at one of our clinics with the DEA and the Oklahoma Bureau of Narcotics and Dangerous Drugs, and they actually performed a sting on a very, I don't know what you call it, individual who was high in their sights that just happened to be coming to our clinic looking for narcotic medication. So, we've had a real struggle here in Oklahoma. We have seen with the tighter regulations of the hydrocodone-combined medications that we've seen an increase in heroin use here in Oklahoma. It's an unfortunate trade-off, but it seems that heroin is much cheaper than prescription medication on the streets, and so we have seen an increase in heroin use here in Oklahoma. So I looked at more of the literature looking at alternative pain treatments and looked at what else is being used to treat pain outside of medication. And, it looked at manual medicine, which really consists of manipulation and mobilization, massage, and looked at acupuncture. And acupuncture has been around forever. It was traditionally derived from Chinese medicine. And that's characterized by the insertion of solid metallic needles into the skin at specific sites. I looked at yoga, which focuses on relaxation, meditation, and stretching. And I even looked at the use of static magnets and a variety of supplements that are used to treat alternative pain, or that are used as alternative pain treatments. Now, I'll say that some of the barriers that we've incurred, and we'll talk more about this a little later, with a lot of the alternative pain treatments is they're not covered by insurance. And it's difficult for a lot of our patients that we see to pay for these alternative pain treatments out of pocket. Elizabeth says, how do you approach the patient who has come in frequently with chest pain and has been given morphine for this, and now is it a rarity? You know, Elizabeth, I think it just comes down to having those difficult conversations with your patients. And if it becomes a frequent occurrence, asking those questions to find out what else is going on, what's bringing them in for that chest pain. Is there a mental health component related? Is it a drug-seeking component? But having those serious conversations with your patients, and they really not only can be serious but scary for providers. You know, I've worked with providers that have been threatened. I've been threatened when I don't prescribe a narcotic. It's happened to me before, and it's happened to a lot of providers that I know. So making sure that you have an escort in the room with you, I highly encourage when you're having these difficult conversations with patients to always take an escort with you and to keep yourself safe. How receptive have patients been to alternative pain treatments? You know, I have a lot of patients who love the idea of alternative pain treatments, but the barrier is financial resources and having the money to pay for these alternative pain treatments. There are a lot of essential oils that we can recommend. Acupuncture is fantastic with the manual medicine, and there are a lot of supplements, but it comes down to, can they pay out of pocket for these treatments? And can they afford to look into supplements or yoga or acupuncture, or are they even in physical condition that they can do this? Oh, Elizabeth, you bring up a great question. Our patient satisfactions have been tied to how well has your pain been managed, and I hear that a lot, and that's extremely frustrating and extremely difficult. Because our perception of how well we treat a patient's pain, as you know, is very subjective, and the response that you have from patients can be totally different than what the provider thinks. And I hate that patient satisfaction scores have been tied directly to how well a patient thinks their pain has been managed. Carolyn has mandatory takedown classes every year across the VA. Good. So, let me see where I'm at. Here we go. Next slide. So the research design that I utilized was a phenomenological method. And the first step in the systematic investigation of this lived experience was to identify if the research problem was best examined using the phenomenological method. Now, phenomenology is appropriate when it's important to understand several individuals' common or shared experiences of a specific phenomenon. It's important to really understand what these experiences mean to each individual, and they can manifest themselves differently based on each individual's experience. So the next step in the process was to identify that phenomenon of interest, which was looking at the FDA upscheduling of prescription drug abuse. And the aim was to describe as accurately as possible the phenomenon, refraining from any pre-given framework, but remaining true to the facts. So the data was collected from participants who've worked in the area of interest. So those were nurse practitioners who have worked with patients before and after the upscheduling of of hydrocodone-combined products. And specific questions were formulated. One question I asked was, have you noticed a change in how you manage your patient's pain since the upscheduling of hydrocodone? I asked these participants to tell me a story about a patient's pain that was affected by the change in the upscheduling and how the scheduling affected that clinician. The data was analyzed, and significant statements and themes were used to then write a description of what the participants experienced. So the target population of my study were advanced practice registered nurses practicing in healthcare clinics in Oklahoma. I had a large accessible population, but I actually reached saturation pretty early on. So I didn't have as many participants as I thought I would, because again, everybody kept telling me the same thing. So the research interviews were conducted in a quiet, private office location at the discretion of the participant, of the APRN that was participating. They were the ones that selected the location. And it was based on geographic location. So I wanted, again, to kind of get a feel for APRNs that were practicing not just in the metro area, but that were practicing in the rural and underserved communities in Oklahoma. So I had quite an array of APRNs in practice settings. Now the participants, they had to be an APRN. They had to have at least a master's degree, and they had to have authorization to practice and prescribe here in Oklahoma. Each participant supported that he or she was independently able to conduct personal business and legal transactions. They had to be 21 years of age or older, and they had to communicate in English. The only exclusion criteria was if they didn't meet the eligibility criteria. So when we talk about research design and we talk about rigor, we have several areas of rigor, and it's essential for all qualitative researchers to establish rigor in their research methods. The rigor of the methods should be defended by defining the stages of the process while arguing that there should be room for creativity within that data analysis. So we have all of these areas, and I won't bore you to death talking about fittingness and audibility and credibility and trustworthiness and saturation, but they were all very important areas to look at with the research design using a qualitative approach to my research. So we just wanted to make sure that I had a solid research design and that I knew when saturation was reached. And that's one area I will hit on. So saturation in a qualitative research refers to data saturation, and that occurs when there's no new information being seen or heard. And this is when it's determined that sufficient data has been collected, and it's also referred to as informational redundancy. So again, I had a large group of APRNs that were willing to participate, but I reached data saturation much earlier than I expected in my research findings. So an interview guide was developed to investigate whether APRN's pain management practices changed after the upscheduling of hydrocodone combined products. There was a purposeful sampling that was utilized by selecting participants based on characteristics like being a good informant, willing to participate, knowing about the information that was required, and someone that was willing to really reflect on that phenomenon of interest. The participants needed to have enough time to participate in the research, and they needed to, again, be willing to participate. I didn't have any trouble finding willing participants. A lot of nurse practitioners were all experiencing the same problem here in Oklahoma, so I had a lot of people that were willing to jump on board. So participants were selected, and information gathering then began, and it continued until data saturation was reached. Now, that saturation provides with certainty and confidence that the analysis is strong and that the conclusions will be right. When the data doesn't offer any new questions and no new direction, there's really not any need to do any further sampling with qualitative research. So I had 4 open-ended questions that I asked, 4 demographic questions that were asked, and all of this was included in the interview guide. The open-ended questions were discussed earlier, and we'll examine the context or the situations that have typically influenced or affected the participants' experiences with the upscheduling of hydrocodone-combined medications, and how they changed their pain management practices in the clinics where they were currently practicing. Now, the demographic questions, it included information about what types of patients did the APRN see. It asked questions about the practice setting. I wanted to know the highest degree that was earned by the APRN and how many years had they been practicing. Each of these interviews were set to last about 60 minutes, and they were all audio taped. And data collection occurred over about a 30-day process or a 30-day period, and it was at the convenience of the participant at the location of their choosing. The qualitative analysis was completed utilizing the steps outlined by Georgie. I read the entire transcript of one of the subjects, and that kind of gave me a sense of the whole. So the data was read a second time and marked or highlighted, and this is how I identified the themes between each of my participants. So when I examined all of those themes of the upscheduling of hydrocodone combined products, it really brought to light some great information that I'm excited to share with you. Didn't go. There we go. So again, we looked at those demographics at all of the participants worked in a family practice clinic. So I didn't have any specialty clinics. They were all family practice clinics. I had all family nurse practitioners that participated. And these practitioners see patients across a lifespan. So they're seeing babies, kids, middle-aged, older adults, and old adults. So really seeing patients across the lifespan. And an average of 25% of their practice time was dedicated to managing patients' pain. Now, 2 of the participants did have a DNP. The other participants had an MSN, and the practitioners had been working in primary care for an average of 8.5 years. So again, I used Georgie's phenomenological method, and that guided my data analysis. So in that thematic analysis, it identified a lot of things. So the first theme was barriers to effective pain management. And several of the respondents commented that the upscheduling had limited a specific category of providers who provide most of the primary health care to patients in Oklahoma. So we have a lot of FNPs that are providing primary care to a lot of patients. And because of this upscheduling, it created a barrier to effective pain management, which led to increased referrals, limited treatment options, and increased healthcare costs. The next theme that was identified was the theme of nurse practitioner regulation. Okay, so that next theme that I was going to discuss is nurse practitioner regulation. And that theme really identified that, if there was a physician on site, it had a little bit different result for patients. And it also pointed that we needed that consensus for regulatory practice. So the nurse practitioners who had a physician on site were able to continue really prescribing at the same level that they prescribed previously before the upscheduling. So what happened was the patients came in, the nurse practitioner was seeing the patients, they would go to the physician to have the physician write the prescription, and then they would give it to the patient. What this identified was that the physician who was writing the Schedule II narcotic was actually never laying eyes on the patient, was doing no assessment, no documentation that was directly related to their narcotic prescribing. So that was an interesting theme that emerged from the thematic analysis. And then the consensus for regulatory practice. I had a lot of participants tell me that, they just don't understand why we can't practice the same as New Mexico. We could drive just a few hours to New Mexico and have full practice authority. And you come back to Oklahoma, and here we are with regulations for home health, regulations for physical therapy, and regulations for narcotic prescribing. And so it created another barrier for Oklahoma NPs. A lot of us felt that after that upscheduling, we should have at least had the right to sign orders to refer patients to physical therapy if we wanted to utilize these alternative pain treatments, but unfortunately this didn't happen. All right. So another theme that was emerged were the theme of alternative therapies, that we have a lot of APRNs that are utilizing complementary medicine and interventional medicine, stretching, ice, massage, natural approaches preventive approaches, and other interventions like steroid injections and physical therapy as well. So nurse practitioners in Oklahoma are working around the problem of the FDA upscheduling of hydrocodone-combined products, but we are still struggling with treating our patients' pain adequately. All right, let's get into some discussion here. I've got some discussion slides and some recommendation slides, and then, I'd love to hear what your thoughts are and any other ideas that you might have for future research. So with the discussion, we know that we are limited with our treatment options. We're unable to prescribe hydrocodone-combined medications. We don't have many options when it comes to Tylenol with codeine. We don't have dosing options in the variety that we had with hydrocodone-combined medications. We have really heard a lot about side effects with Ultram and patients who are using Ultram and how it lowers the seizure threshold. So it really has boxed us into quite the corner in Oklahoma with our treatment options and not being able to refer patients to physical therapy without the signature of our supervising physician. We have long wait times for referrals. Now, if a patient in Oklahoma, and I know this isn't the same everywhere, but let's just take neurology, for instance. If I have one of these patients who needs to see a neurologist and they're a state Sooner Care patient, and they live here in Oklahoma, let's say Oklahoma City, the waiting list to get into neurology in Oklahoma City for a state Sooner Care patient is 12 months. They can drive north a little over 2 hours to Tulsa, and the wait time is between 6 and 9 months. It's just not feasible for some of our patients. So when we talk about these long wait times for referrals, these patients are still under our care. We're still their primary care provider, and we're still struggling to provide the appropriate pain management options for those patients. The other thing that we found was when we're sending patients now to pain management, that we were managing these patients in the clinical setting on much lower doses of medication. We send them to pain management, and they're being prescribed not only multiple medications, but medications at much higher doses. And if the patients aren't taking those medications and their drug tests come back that they don't have that high level of drug in their system, that pain management is kicking them out. So we're seeing that we have patients who were doing just fine on low levels of hydrocodone-combined products are now on pain medications in combination with muscle relaxants and medication for other pain, like Neurontin is one of the common things that are thrown into the mix there. So we're seeing a lot of patients who are utilizing even more medication after the upscheduling of hydrocodone-combined products. We see an increased expense to the healthcare system. We have more patients visiting ERs, more patients being prescribed narcotics than ever before, and we have longer wait times and limited options for treating patients who truly are suffering from the disease of addiction when they're addicted to prescription pain medication. Here in Oklahoma City, our options for treatment for patients with pain, we have very few beds, less than 15 in the Oklahoma City metro area for drug treatment when it comes to a state patient. And we find that these state patients are struggling more with narcotic addiction than other patients, and they have much more limited treatment options. The length of stay in the only facility that's available for these patients is 7 days. And not a lot can be accomplished in 7 days when it comes to treating the actual addiction. So we are struggling with that increased expense to the healthcare system. We need a standardized regulatory process. We need, again, to be able to practice across state lines and have that interstate communication and collaboration, and be able to understand much easier the practice guidelines for APRNs if it was consistent across the United States. And we realize that we are utilizing alternative therapies. We have to educate ourselves when it comes to the use of alternative therapies and look at the evidence that is behind the use of alternative therapies, but we also need to look at our patients and make sure that they're able to afford financially utilizing alternative therapies, because a lot of patients are on a very tight budget and they're not able to afford to go for massage or acupuncture or over-the-counter options that are available through some of the health food stores. So we have to be careful with our treatment options of those patients. So it's recommended that future research is done with similar studies to really examine the FDA's upscheduling of hydrocodone and the effects that it's had on nurse practitioners' pain management. Regulating agencies working together for a standardized approach across the U.S. would be fantastic. I think we are all looking for the same end result. We just have to figure out a process to get there. Campaigns need to be conducted across the United States, and they need to be focused on regulatory practice. We need to bring together in every state, in each association, all APRNs, family medicine, acute medicine, CNMs. We need to bring everyone together under that lumped phrase of APRNs, and all of us work together for the main goal of full practice authority and a consensus model across the United States. We need clinic-specific guidelines for referrals, and we need to collaborate with other healthcare providers. I make calls to other healthcare providers frequently if I have a patient that comes in that's demonstrating drug-seeking behaviors, and I see that another provider has prescribed a narcotic medication recently. I'll call them up, and I don't have to pull them out of clinic, but I can leave a message for them to call me back on their own time. And so really collaborating with these healthcare providers about patients' behavior, and then collaborating with specialists about the way the patient's pain is being treated is really important for nurse practitioners. We need to make sure that we are collaborating with specialists and other providers when it comes to our patients. Remember that effective pain management is a moral imperative. It's a professional responsibility and the duty of people. It's our duty in being in the healing professions that we are looking at effective pain management. Pain results from a combination of biologic, psychological, and social factors, and recourse to prevention and management. Chronic pain has such severe effects on all aspects of a person's life that every effort needs to be made to achieve both primary prevention and secondary prevention through early intervention. And that's what we can do as healthcare providers. The effectiveness of pain treatments depends greatly on the strength of the clinician-patient relationship. We need to remember that pain treatment is never about the clinician's intervention alone. It's about the collaboration, again, between the clinic or the clinician, the patient, the family, other healthcare providers, and other specialists. So this is a group effort, and it just doesn't have to be what I say because I'm the provider. I need to listen to my patients, listen to what their goals are of effective pain management, and work together to reach those goals with a mutual relationship. So let's talk briefly about a diversion prevention program. Now, a diversion prevention program needs to be developed in whether it's a clinical setting or a hospital setting. I think a diversion prevention program is extremely important, especially if you house narcotics at all in your clinic. It's important to remember that our patients are the only ones that struggle with prescription drug abuse. This could be another provider, another nurse, another staff, whether it's in a clinic or a hospital environment, and that we need to have policies and procedures that are in place to minimize any possible diversion. We need to create standards for ordering and prescribing controlled substances. And we need to establish education and training across multiple disciplines to educate staff on controlled substance diversion. Utilizing that information about what those common characteristics of drug-seeking behaviors are, and getting our staff and our nursing involved in looking at the PDMP with healthcare providers. Now, a diversion prevention program involves a lot of steps, but it doesn't have to be too consuming. Just think of all of the good that we could do if we had a prevention program in place before anything happened. So it's important to review policies and procedures that are in place currently to minimize diversion. If you don't have any policies and procedures in place, it's important to develop policies and procedures. You want to review and audit controlled substance data in clinic and hospital organizations, and there are tools that are available to help assist in identifying gaps in systems and develop long-term solutions. Beyond following the law, having these monitoring tools in place ensures that there are no gaps between dispensing controlled substances and administering those medications to patients. It's important to create standards for ordering and prescribing controlled substances. That's what our work group did here in Oklahoma, is we developed guidelines for ordering and prescribing controlled substances in the clinical environment and in the ER environment. And we developed these based on some fine examples of what's been done in a few other states. Now, these standards should include maintaining a chain of custody and utilizing witnesses if you're in the hospital setting and you're disposing of controlled substances, and always be aware of the amount of medication that's being dispensed and signed out. It's important to establish education and training across multiple disciplines and to educate staff on controlled substance diversion. Staff needs to understand the issue just as well as the provider and the nurses. They need to understand the issue, the risk to the patient, the risk to the business, and how that they can be involved in reducing diversion. Train staff on what to do if they suspect a coworker's diverting, and healthcare professionals have that ethical duty to protect patients. Part of this responsibility is to report impaired staff members so they get the help that they need as well. I encourage any business, whether it's a clinic or a hospital, to have cameras in high-risk areas. These can be useful monitoring tools. And when something does go wrong, have procedures in place to launch and investigate potential cases of diversion and discrepancies. Again, we want to help people get the help that they need for their addiction. Review staff practices that can help avoid the problem on the front end by reducing the vast number of opioid prescriptions that are being written. That's another goal we have. If we can just decrease the root of the problem, which is the provider, it will have a tremendous effect. So learn, realize, education, and rely. You want to learn about it. Educational resources are really important for nurses and nurse practitioners. As we become more aware of the problem of opioid abuse and the epidemic, it really is empowering. It's an opportunity to learn what to look for when nurses or other providers are taking care of patients. The nurses are at the forefront of dealing with patient care and more apt to really identify when a patient they're working with might be struggling with an addiction. We need greater research and more media attention around the opioid addiction problem and the epidemic, and this attention would really help to decrease and bring awareness to the issue. To make greater strides, nurses need to have a deeper understanding of what dependence and addiction truly means. We need to understand that this is a disease and that these people need help. Nurses and nurse practitioners need to understand the neurobiology of dependence and the impact on the brain. It's quite fascinating. Additionally, knowing that each individual responds differently to opioids, nurses must understand discrepancies and addiction behaviors in patients. It's important to use open-ended questions and reflective language. This really will help you get the most information out of a patient and gain as much history as you can. Open-ended questions and reflective language has one of the key techniques that I find helpful in identifying if a patient is struggling with prescription drug abuse. You need to realize that addiction impacts the whole family. It's not just the patient that's suffering. It creates fear and chaos in the home. It can split families apart. And when there's a lack of awareness or a stigma, and families are afraid to ask for help, they don't know where to go for help, and they don't know who to ask. So we need to be in tune and engaged with our families so that we can give them the necessary resources that we have available in our communities to help decrease the epidemic of prescription drug abuse. It's important to educate patients and their families on painkillers and what are they, where do they come from, why is this happening? And it's so important to talk to parents about keeping medications locked up in an area away from children and away from visitors to decrease diversion. So we need to make sure that families and patients understand how addicting some of these medications are that we prescribe. We need to have those conversations with our patients and with our families, and that we need to raise that awareness for the family and let them know that we're here to help. We also need to rely on nurse leadership. Nursing leaders need to make sure their organizations are educated on opioid addiction. Recently, the American Organization of Nurse Executives, they discussed one of the most pressing issues that are facing hospitals and other healthcare settings across the United States, and we need other organizations to really jump on board and help educate the public on prescription drug abuse and how we can decrease this epidemic. Educational courses are a great starting point to fighting the opioid abuse, but nurses also rely on nurse leadership to recognize the importance of education on the issue. So again, ongoing education will help understand the complexities of addiction, and it'll allow nurse practitioners to effectively deal with the epidemic, and in the end, it'll really save lives. So I encourage you, if you are a nurse practitioner and you're practicing and prescribing narcotics and you have a prescription monitoring program in your state, I encourage you to utilize that prescription monitoring program for all new patients you see and every time that you dispense a narcotic prescription to your patients. I encourage you to educate your patients and your family, your staff and your nurses about opioid addiction, opioid abuse, and opioid misuse, so we can all come together and help decrease the problem of prescription drug abuse that we're facing across the United States. So we have a fantastic career as APRNs. We really do influence our patients' care, and I appreciate you all. I know we're a little quicker on time than I expected, but I was hoping to have at least half an hour for some discussion. So I would love, if you want to join with a microphone or in a chat box, let's go ahead and start the discussion about prescription drug abuse and what you're seeing in your areas. Teresa says, I'm sorry, I don't know why I muted. Is somebody joined by microphone? I used my PMP and it found abuse and doctor shopping. Absolutely. So Teresa, again, when you look at the PMP and you're extracting that information, I always take it with me into the patient's room, and I tell them before I go that, I look up every patient that I have that's a new patient, and I'll be right back. I'll probably already have it pulled, but I'll walk out of the room and come back and say, this is what I've looked at, and I have some concerns, or I don't have concerns. But I use the PMP as a discussion piece, and it really helps me to open those doors with my patients to have that hard discussion. What's going on in your life? Is this an acute pain, a chronic pain, a low back pain, or are we really having problems with prescription drug abuse, and are you having some struggles with addiction, and what are the components that really led up to that? So, the PMP is a really great tool to open the line of communication between provider and patient. So what questions do you have for me about my research? I appreciate everybody taking their time out during the week and of an evening to listen to all the work that I've done, looking at prescription drug abuse, looking at the FDA upscheduling of hydrocodone, and I want to continue to carry out my research and hopefully make a bigger impact, a bigger difference here, not just in Oklahoma, but across the United States when it comes to helping decrease this epidemic.
Dr. Mack, I have a question. This is Dr. Gardner.
Yeah, hi, how are you?
Fine, thank you. This has been wonderful information. The
Thanks.
question that I have is regarding uploading the CSPMP into the patient's chart. You said in the state of Oklahoma that you are not allowed to do that. Now, you're not allowed to do it and attach it to a note. Can you upload it into the chart as a separate document? No. And where did you find those guidelines?
I found that with the Oklahoma Bureau of Narcotics and Dangerous Drugs. When I started working with them, I got really involved. I went and did some training with them and got to learn all about their operations. And when we were talking about this and we talked about the PMP and how we could use that with the medical record, that's when I was informed that no, you can't attach it to the medical record, but you can type everything in the disposition. When you go to locate that information on their website, it's very layered and it's not easy to get to. And I don't think any of us knew that that wasn't appropriate. And so when we developed our state clinic and emergency room guidelines, we actually put that information out there. We did a quick tip sheet with our PMP, when you should use it, what you should look for, and kind of like a do's and don'ts. So now all of our providers have access to it. But for so long, I know of a lot of providers that were scanning it into the chart, and we didn't know that that wasn't legal.
Did they ever tell you, did it give you the rationale as far as why you can't upload it into the patient's chart?
Because it's not part of their medical history. It's not part of their actual visit. It's an outside system, and it's not integrated with the EMR. So if it was like an integrated component with the EMR, then you could upload it. But since it was coming from an outside organization, you weren't able to attach that to the medical record.
Thank you.
You're welcome. Thanks for the question. Got a lot here in the chat box. I'm going to scroll up. All right. Teresa says she lives about 2 hours from Chicago and has a terrible opioid abuse. Thanks so much for this. You're so welcome. I would love to share my educational packet and help anybody if you have, if you want to implement any of this into your clinical practice site. Pennsylvania only came on board with the PDMP in late 2016. Most of our recently Epic EHR allows us to view with one click in real time, which is wonderful. That is wonderful. We still, we're not able to view Arkansas still here in Oklahoma. We're up to 14 states that I can look at, but I'm unable to view Arkansas, which is one of our surrounding states, and one area in the state where we have a higher incidence of opioid abuse. So I'm hoping, eventually they'll get on board as well. But we still have a few states who aren't utilizing a PDMP, and they're not sharing that information across the state lines. So interstate communication with the PDMP is extremely important, and making sure that there are guidelines for pharmacists is really important as well. We were having trouble back in 2011 that pharmacists didn't have to enter the information immediately or within 5 minutes of dispensing. So you might have a patient who received a narcotic, 10 days ago, but it still hadn't entered the system. So when we made the change that the information had to be entered within 5 minutes, it made a huge difference for providers because we could see the information right now and when it was happening, whereas before we weren't able to. Mary says, I live in Dayton, Ohio, and we have the highest rate of opioid abuse. In primary care, we found it difficult to do pill counts, drug screens, etc. in a timely manner. Any suggestions? Yes, Mary, this is so I don't mean to sound harsh, but this is where we have to look at our business and think, should we see more patients, or should we decrease the number of patients that we're seeing in order to implement improvement projects in our practice that would lead to more positive outcomes? So when we first started about just looking at the PDMP, I heard from not just nurse practitioners and PAs, but other physicians here in Oklahoma who say, you know, I don't have time. I'm trying to see 40 and 50 patients in a day. Well, personally, as a provider, I don't know what kind of care you can provide when you're seeing 40 to 50 patients a day. So if you're struggling in an area where you do have these high rates and you do have a lot of drug-seeking behavior, you know, I really encourage that business to take a step back and look at how many patients they're seeing in a day, and think of areas that they can implement some of the screenings that do not detract time away from the provider, because I understand it's still a business and we have to get paid, and to do that we have to see patients. But we also need to provide safe, effective care, which means looking at those contracts for pain management patients, looking at the drug screening, and really utilizing what we have available in the clinic. So it's a tough one, Mary. We decreased the time, or increased the time that we were spending with patients where I'm currently practicing, and making that time adjustment was extremely helpful. It was only a few minutes on the schedule, but you know, there were patients that I had those extra 5 minutes built in that I didn't need, so I could catch it up somewhere else, and it really did work for us. Oh, Brittany, yeah, if you'll send me a private email, I'd be happy to look for the link. Now, remember that things with the PDMP are like our licensing. It's all state specific. So if you're not in Oklahoma, it might be okay for you to upload it into the chart. But in Oklahoma, uploading the PDMP to the chart or attaching it to the chart is just not an option. Yeah, Brittany, you're in Texas. I'm not sure about your specific practice guidelines. Where I'm at here. Oh, Dr. Kit Devine says, can you tell us how to obtain a certificate or proof of participation in tonight's excellent session? Well, thank you for your kind words, and I believe that you will receive an evaluation. I've got some questions that I've put together that you'll answer, and then after you answer those questions, you should receive your certificate for the CE session tonight. Carolyn says, her script info is documented by the clinical pharmacist. Marie says, in Indiana, the last time I checked, you could not legally scan the report into the medical record either. Yeah, and you know, I would love it if it was like in Epic and you had that one click. That would be so much easier. We're still not as streamlined as I would like to be here in Oklahoma, and it can be a lengthy process. You have, you know, patients, I hate to say, patients can be really tricky. So what I've learned when I look at the PDMP is that I look at the patient's license, their driver license that they have submitted for the clinic, and I look at the name and how the name is spelled there, because I've had different names submitted to the clinic that the patient goes by, which isn't their legal name, and the legal name is a lot of times what they have that narcotic prescribed under. So we have the option in our PDMP to enter a partial name, and for the first and the last name with a date of birth. And that's really helped, because sometimes you might have someone like the pharmacist inputting that information and it is inputted incorrectly. So if you just put in a partial first and last name, you'll be able to identify the information about that patient. Carolina says, it would be great to access all states, as many people travel now and get their opioids in different states. That's correct. And that's why we have the option of looking at several states now, but it's not everybody, you know, it's not everywhere. And if you were in Oklahoma and in an 8-hour day and you were really, really determined to obtain narcotics, you could literally go and have an appointment in Oklahoma, have an appointment in Colorado, New Mexico, Texas, possibly even Kansas, and obtain narcotics from each state in an 8-hour day if you were in the right location in our state. So it is really important for all states to communicate. I can't stress that enough. Go back up here. Have you seen the latest 60 Minutes episode regarding the changes? Oops, jumping around, sorry. Regarding the changes at the FDA and the opioid crisis, it's fascinating. It is fascinating. There's a lot of information that is available about the opioid crisis. I have been contacted multiple times this year to host presentations, and it's so exciting to see where we've come from just since 2011 with the opioid epidemic that we're facing and how much progress we've made. And so it really is very exciting. I'm glad that we're finally getting the word out. Lynn says, I've learned a great deal and will go back to my state board of pharmacy in Nevada to get a tutorial for the PDMP. I must admit, I've relied on my medical assistant and don't have a clue how to log on myself. As a nurse midwife, I primarily prescribe narcotics during hospital discharge and sadly never do a search. I'll consider changing this practice immediately. Well, thank you, Lynn. I appreciate it. You know, if we can just, or if I can just change one person's mind in every state, that person can carry the word forward and help influence other providers about the tools that we have available and how important it is to utilize those tools. Teresa says, I agree on the 60-minute piece. I'm glad the media is saying, hey, this really is a problem. And the slides, let me see what Bob says here. You should be able to download a copy of the presentation. Bob, was that coming from the email announcement? I think it was the email announcement that said, you know, go to Big Blue Button and go to this room, and I think the slides might have been attached. See if you can confirm that for me. And then I believe, Diana, that the questions and the eval will be sent via email. And it should give you a link to click on to answer those questions. We have one that says, will it be sent to our personal email? I've not used my school one in 7 years. Now, you know, that's a really good question, and I don't have the answers, but I will find out for you. Let me see if Bob happens to know. Let's see if we've got Angela or anybody else here on the call. Give me just a second. See if someone can help me answer those questions for you. Bob says there's a button under the slides where you can download a copy. We don't know about the email situation. We'll wait on some other questions to come up. Let me go over here and see if I can get a hold of someone that can help me answer the CEU credit and how that works. Just a second here. Let's see if I can get an answer. Hopefully she is on Hangout. Let me go back up. I don't have an answer to the email question. I apologize. I'm hoping to have an answer shortly. Let's see if we can get one. Okay, Angela is coming in to let us know how we do all of that. She'll be right here. So give us just a second and we'll figure out the CEU or the CE portion. And she'll let us know how that works. I'm glad you enjoyed the presentation. I really am passionate about this topic. And I'll provide you with my email in the chat box. If anyone has any questions for me, or if you want to run anything by me or you want to implement anything, please let me know. I'd love to work with you. If you're interested in the hot topic of prescription drug abuse, I'm always willing to look at some collaboration opportunities for getting this information out there and getting it published. So I have submitted for publication my information over my dissertation, crossing my fingers that I'll hear something positive soon. And yes, you'll be able to access this information from the Digital Depot at Frontier. The recording will be posted. Do you feel it was difficult to get all of, oops, hold on one second. Do you feel it was difficult to get all of the providers in one location on the same page regarding prescribing and monitoring opioids? I feel like some of the providers in my area are very resistant to looking for alternative pain control methods. So a patient just has to go to a different provider to get the opioid, whether it's appropriate therapy or not. And yes, this is a real struggle that we face. Let me come right back to that. I think Angela's on with us now to talk about the CEU certificate.
Hi, how is everyone? I am going to provide a link for you that is to the post-test and evaluation for this form. I apologize that this was not sent to you previously, but you will need to copy the link to this form that I'm putting into the chat box and take this short evaluation and post-test. Once I get your form submitted, it might take me up to a couple of business days to get you your certificate emailed to you, but I promise you will get it. And if for some reason you don't get it, you can always reach me by email or phone, which I am also going to post in the chat box.
Thank you so much, Angela. We appreciate it. So back to that last question about getting other providers on board. I think that that's another difficult conversation to have, and it needs to be very professional. And I've had a lot of those difficult conversations, especially when it comes to other physicians here in the state, and they are difficult and sometimes painful conversations to have. And I think until you know, everybody that provides care, all providers can really understand what APRNs do and how we are educated and how we're trained. But making sure that you're educated and knowledgeable about the opioid epidemic that not only we face in the U.S., but in your specific state will really help to sell this to other providers and to get them on board. And I think just looking at some of the statistics on, you know, what has changed, the statistics about how many narcotics are being prescribed versus how many people are still addicted to these medications, and looking at the old National Survey on Drug Use and Health and then comparing it to our recent results is another area that can help provide that information. But again, it's just having those difficult, respectful conversations. And I can't stress that enough when it comes to policy, full practice regulation, having conversations with patients about opioid abuse, misuse, or whether it's a staff or another nurse, whatever it might be, making sure that you're knowledgeable, that you're having a respectful conversation. We need to make sure that we understand that we're not the only one going through this problem. A lot of times our patients and our families are as well. So being respectful is extremely important. And thank you for all the kind comments in the box. I've had a great session tonight. I really enjoyed sharing everything that I've learned over the past several years with you. I am going to continue to do my research and continue to spread the word about prescription drug abuse and the epidemic that we're facing, not only in Oklahoma, but across the U.S., and hopefully continue to make headway on decreasing the problem. And again, you're welcome to send emails to communicate with me. I'd be happy to answer any questions that you might run across after we're finished with our presentation tonight. Peggy said, it's nice to know our practice is already doing the recommendations. Thanks so much for your validation. Absolutely, Peggy. You're very welcome. All right, I know we've ended about 30 minutes early, but I'll stick around and wait and see if we have any other questions. We'll keep the recording going for a few more minutes and see where we're at. We've got, Angela, it looks like we might have a problem with the post test. I think there's one that's a multiple answer on question 11, and it won't let her submit 3 answers. We'll take a peek at that, and she's looking at it right now. Thanks for letting us know and bringing that to our attention. Yeah, Kristen, it is such a sad epidemic. Been a nurse in addiction field for 7.5 years and now a new FNP. Angela's working on question 11. We'll see if we can get it fixed. I appreciate everyone coming tonight and again listening to all of the work and all the research that I've completed on prescription drug abuse and the FDA's upscheduling of hydrocodone. I sure hope that we can eventually implement a consensus model across the United States and get everybody on the same page. Angela said she's fixed question number 11. You might need to refresh. Mary wants to know when the recording will be available. She missed a little due to student advising. Mary, I'm not sure. Maybe Bob or Angela can jump in. I think there's a little editing that'll be done, so it might be a day or two. That's just my guess. Elizabeth says, I am unable to copy and paste a link from this computer. Can I private message you? Yeah, and let me find the link so I have it as well. There it is. Yep, and I've grabbed that link, so if anybody needs to private message me, you're welcome to, and I can send that to you. Mary says, since she was a little bit late, can I still get the CEUs? Mary, yeah, you should be able to watch that recording and do that. The video will be, or the recording will be available in a day or two, and it will be located at the link that Angela has provided. It'll at least be a few days, Bob says. It's a long video, and it's going to take BBB some time. Here's the link to the post-test. And here is my email address. You're welcome. All right, I guess, Bob, we could probably go ahead and stop that recording, and I'll just stick around while people trail out and see if anyone has any other questions before I sign off. Does that sound okay? All right, thanks, Bob. I appreciate your help tonight with the